Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 377 of our pharmacotherapy series, which majors in pain and its management. The first case reads, BYB is a 46-year-old female who sustained a shoulder injury while pulling a cart at work. She will be undergoing shoulder arthroplasty in 2 weeks. She also has fibromyalgia and takes hydrocodone co-formulated with acetaminophen 5/325 mg dosed at 1 to 2 tablets by mouth every 6 hours. Usually takes 8 tablets daily, as well as duloxetine 30 mg by mouth daily and pregabalin 75 mg by mouth twice daily. She smokes 1 pack of cigarettes daily and has, in her own words, a few glasses of wine nightly to help her pain because she does not think her current analgesic regimen is effective. So my question to you reads, what assessment should be done with BYB prior to surgery? What risk factors does she have for increased pain after surgery? It is paramount that all patients have a thorough preoperative assessment, including review of medical comorbidities, medications, history of chronic pain, and substance abuse, as well as prior postoperative analgesic regimens and responses. This might include evaluating kidney or liver function, pulmonary function, or coagulation status. Pharmacists should also ask about sleep apnea. The presence of central or obstructive sleep apnea is associated with a higher risk for perioperative complications, including opioid-induced respiratory depression. If the patient does not have a sleep apnea diagnosis, a screening tool called the Stop-Bang questionnaire can be utilized to assess the risk. The results of this screening are associated with postoperative critical care admission. As part of a medication review, the pharmacist should consult with the respective state prescription drug monitoring program to determine what controlled substances the patient has been filling. It is expected that patients have only one prescriber of controlled substances, so it is helpful to determine whether stated use matches the prescription history. Keeping with the Joint Commission standards, the pharmacist should reconcile outpatient medication profiles, contacting dispensing pharmacies if necessary. Current and past substance use should be addressed in an open and non-judgmental manner. Some hospitals perform urine drug testing to confirm prescription and/or illicit drug use. Patients always bring their past experiences and current fears to surgery. These factors affect how they perceive and cope with acute pain after surgery. Risk factors for increased pain after surgery in BYB include female gender, work injury, and chronic opioid therapy. Functional pain syndromes such as fibromyalgia are associated with inefficient diffuse noxious inhibitory control, abbreviated as DNIC. This means that the inhibitory pathway is not effectively blocking pain transmission into the CNS, and she will likely have an exaggerated pain response to surgery. Her chronic opioid use could also complicate pain management, because she will likely require higher opioid doses after surgery. My next question to you reads: what should be done to help BYB prepare for surgery? Clinicians should provide the patient and family with individually tailored education, including information on treatment options for management of postoperative pain, making sure to document the plan and goals in the medical record and on paper for the patient to take home. Patient-tailored education has been shown to reduce postoperative opioid consumption, reduce preoperative anxiety, reduce requests for sedatives, and reduce length of stay. Education should include changes in analgesics prior to surgery, reporting and assessment of pain and when to report, multimodal pharmacologic and non-pharmacologic options, as well as realistic goals for pain control. For BYB, there needs to be education about her substance use. Many surgeons require patients to stop smoking prior to surgery to improve healing. Given her regular intake of alcohol, tapering off this prior to surgery is important, because she may develop alcohol withdrawal after surgery if she continues to consume alcohol. This complicates postoperative care and prevents use of valuable analgesics such as acetaminophen due to additive liver toxicity. Because she is getting little to no benefit from her opioid, it is recommended to discontinue hydrocodone, acetaminophen via taper over the next 2 weeks to reduce her tolerance and improve her postoperative response to opioid analgesics. Some time needs to be devoted to reducing her anxiety and educating her that she may have an exaggerated pain response. Increasing the dose of pregabalin may help with this as part of a multimodal analgesic regimen, and duloxetine could be continued. The next question reads: based on current guidelines, what postoperative pain management approaches are appropriate for BYB? Clinicians should use regional or intraspinal analgesia whenever possible to reduce the neuronal response to surgery. Surgery in the extremities is most often managed with regional nerve blocks, using a local anesthetic such as bupivacaine or ropivacaine. There are both sensory nerves and motor nerves that extend from the spinal cord. The sensory nerves carry pain, temperature, pressure, and chemical messages from the area of injury to the spine and brain for processing. Sensory nerves are small and very sensitive to local anesthetics. Local anesthetics act as sodium channel blockers and, depending on how concentrated the local anesthetic is, that is 0.05% versus 0.1%, it is possible to achieve a very dense block and completely stop transmission. Unfortunately, with a really dense block, nerve transmission is retarded or stopped in the larger motor nerves as well, causing loss of motor function. For BYB, the anesthesia team will consider a nerve block, likely an interscalene nerve block, either as a one-shot block or a continuous infusion. The one-shot blocks only last a few hours. Because shoulder surgery is so painful and recovery so long, some hospitals send patients home with a continuous infusion of local anesthetic for pain relief up to 7 days. If they do this for BYB, she will have her arm in a sling because her arm and hand will be numb and not functional while the nerve block is running. This form of longer-term acute analgesia has been shown to reduce length of stay as well as provide excellent pain relief. Some surgeons use local anesthetics for localized joint or tissue infiltration in and around the surgical incision to offer short-term analgesia. A liposomal bupivacaine may be used as well. This may offer slightly longer analgesia in the area where administered. For thoracic and abdominal surgeries, there are several analgesic options to reduce opioid need. Spinals are one-time injections of either opioid and/or local anesthetic into the subarachnoid, that is intrathecal, space. Because this is not a continuous infusion, the analgesia will wear off according to the half-life of the drug used. Some anesthesiologists use a small amount of epinephrine to cause local vasoconstriction and keep the medication from dispersing through the cerebrospinal fluid. Common complications with spinal injections include post-dural puncture headaches, i.e., cerebrospinal fluid can leak after puncture of the subarachnoid dura, and itching, with opioids. More serious complications include delayed respiratory depression, with opioids, hypotension, with local anesthetics, infection, and intraspinal hematomas. Epidurals offer the convenience of a continuous infusion of opioid and/or local anesthetic. The medication chosen, concentration, and infusion rate all offer different options for a given clinical situation. Morphine, hydromorphone, and an agent from the fentanyl family are the opioids most commonly used. The P, K, A and lipophilicity help determine the best agent. Morphine and hydromorphone are more hydrophilic, so it is more difficult for them to pass through membranes, to get into the cerebrospinal fluid or systemic blood, once injected into the epidural space. This is advantageous because they stay in that space, and infusions can be used for up to 7 days. The fentanyl-related agents are highly lipophilic and easily pass through membranes into the systemic circulation and cerebrospinal fluid. Typically, they are not used for longer than 24 hours due to this, but are often used for epidurals during labor. All epidural opioids travel cephalad to the brain via the cerebrospinal fluid and may cause central respiratory depression. Epidural opioids also cause typical class-related adverse effects such as itching and nausea, and cognitive effects such as sedation or confusion, although these are centrally mediated. Some clinicians limit opioid use further by only using local anesthetics in epidural infusions. The local anesthetic chosen depends on half-life and toxicity. Lidocaine is used for local infiltration because it has a short onset of action. However, it also has a short half-life, so usually bupivacaine or ropivacaine is used for blocks. Usually these are infused via an epidural catheter. The catheter tip is placed where the densest block is needed. The greater the concentration, the denser the block. Increasing the infusion rate causes the local anesthetic to spread over more spinal nerve roots. This causes a greater clinical area of anesthesia. For example, if a patient has a total colectomy and the incision area is still painful on the most cephalad part, the infusion rate can be increased so some of the higher nerve roots are covered. Local anesthetics must be monitored not only for pain coverage but also for toxicity. They most commonly cause hypotension, because sympathetic nerves are small. The more cephalad the epidural catheter tip is placed, the more likely that the sympathetic nerves serving the lungs, diaphragm, and heart will be affected. Local anesthetic systemic toxicity, abbreviated as LAST, can be life-threatening, causing seizures and cardiac dysrhythmias. The treatment of local anesthetic systemic toxicity involves rapid administration of intralipid, which will bind the local anesthetic. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 378.